Good afternoon, everyone. Welcome to our webinar this afternoon between CMQCC and Anthem Blue Cross. I'd like to thank you for joining us today. All the lines have been muted to eliminate background noise, and we will address questions at the end of the webinar via the chat box or the Q&A. So if you have a question, you can type it in either of those places. The webinar recording will be available on the CMQCC website in several days, probably Thursday or Friday of this week. And if you have any other questions, you can contact me. This is Valerie Cape, vcape@stanford.edu. Next slide, please. Today, we're going to be talking about improving birth care experiences and outcomes for, by, and with Black mothers, a quality improvement approach. Next slide, please. This webinar will offer CME credit. Anthem Blue Cross is providing it, and each webinar participant will receive one continuing medical education unit approved by the American Association of Family Physicians for attending the webinar today. And at the end of the webinar, we will share with you how you will obtain that CME credit. Next slide, please. With that brief housekeeping, I'd like to turn the time over to Dr. Malloy from Anthem Blue Cross. Dr. Malloy?
Yes, I'm here. Thank you. Good afternoon, everyone. I am Dr. Demetria Malloy, the Provider and Plan Performance Medical Director for Anthem's California Medicaid team. I am very pleased to welcome you to our presentation today, and I'm so encouraged by the high number of registrants that we have. It's just further evidence of the great engagement from our providers and all of our partners that do really important work across this healthcare spectrum. So a little background on us. Anthem has been involved in providing healthcare benefits in California since 1937. And since then, we've developed robust teams in Medicaid, Medicare, and commercial. It's the Medicaid team that brings you this webinar today. And we serve over 1.2 million members in 29 counties across the state. We have a wide range of membership, and as such, we are always looking for ways to better serve our Medi-Cal patients and meet any unique needs. We have a strong focus on mobilizing partnerships to collectively reduce healthcare disparities. So hence our presentation today. We're certainly proud of the partnership we've developed with the California Maternal Quality Care Collaborative, and the topic that will be presented today, improving birth care experiences and outcomes for, by, and with Black mothers, a quality improvement approach. And we have a great speaker to address this important topic. Dr. Elliott Main is the Medical Director of the California Maternal Quality Care Collaborative and has led multiple state and national quality improvement projects. He's also the chair of the California Pregnancy Associated Mortality Review Committee since its inception in 2006. He's currently a clinical professor of obstetrics and gynecology at Stanford University. Dr. Main has been actively involved in or chaired multiple national committees on maternal quality measurement, including those sponsored by the American College of Gynecology, the American Medical Association, the Joint Commission, Leapfrog, and the Centers for Medicare and Medicaid Services. In addition, he helps direct a number of national quality initiatives with ACOG, the Centers for Disease Control, and the Maternal Child Health Bureau, including the multi-state AIM project. In 2013, Dr. Main received the ACOG Distinguished Award for his work in quality improvement. We're so pleased to have him giving this talk today. And with that, Dr. Main, I will turn it over to you.
Well, thank you very much, Dr. Malloy. I must say at the outside that I'm only marginally qualified to give this talk. We are all learning on this, and I wanted to say that we can only approach this with a large group of partners, including community-based organizations, Black scholars, and others. And so it's with that humility that I want to start off the lecture today. We have a long tradition at CMQCC of doing action steps, and I think that's what we're all interested in doing to improve equity in maternity care, is to move beyond the documentation of the gaps in care that we have and to really test different approaches to improving care. We are doing this with groups that are very focused on reproductive justice from around the country, and we want to marry that or partner that with our expertise in quality improvement at the hospital and provider level. So this is really an effort that we see of combining community groups with action steps within the healthcare system. So today we're going to recognize the contributing factors in the variation in maternal morbidity and cesarean rates in California, where we have really excellent data, particularly as they pertain to racial and ethnic diversity and variation. We're going to describe our Birth Equity Collaborative, again, turning data into action. And lastly, we want to put out some principles that you all can use in your home environment, whether it be a community environment or a hospital environment. I do not have any financial relationships with commercial interests, so that makes it easy. CMQCC, I'm going to start with a couple slides about our background. We're a multi-stakeholder organization and started in 2006, so 12 years old, 13 years old now, that involves providers, hospitals, hospital associations, a variety of state agencies, and public groups with a focus on improving maternity care. Our mission is to eliminate preventable maternal mortality and morbidity and racial disparities. We host the California Maternal Mortality Review Committee under the direction of the California Department of Public Health. We share a lot of administrative space with our sister organization who preceded us, which was California Perinatal Quality Care Collaborative, focused on neonatal care. And we've developed quality improvement toolkits and collaboratives on hemorrhage, preeclampsia, venous thromboembolism, early elective delivery, for cesarean prevention, that have all shown pretty significant improvements in care. We also have a very detailed maternal data center that has rapid cycle data that is low burden, that we use extensively for all of our collaboratives, and we'll talk about using it for this one. So our focus is driving maternity improvement at scale, not just 1 or 2 hospitals, but the 230 odd hospitals that comprise California. California has 500,000 births, which is the size of a European country. And so this is, we've been testing different ways of making change at scale that involve these 4 principles. The data-driven through a maternal data center, engaging partners all around the state, whether it's public partners or provider partners or hospital partners, et cetera. Doing implementation, quality improvement, collaboratives, largely based, I would say, in hospitals to date, though we are expanding that out into the community, particularly for this and our opioid project, based on toolkits which serve as background information or the encyclopedia for how to implement projects. Our current projects at CMQCC include 90 hospitals working on reducing cesarean births, so, in the setting of really increasing the support for vaginal birth. We are expanding our data center, also now in Washington and Oregon, and this has been a critical part of supporting quality improvement efforts. We are turning our interest to sustainability. Since we've done a variety of projects in the past, now we're looking at how to keep them up and going and fresh, with a QI Academy, working with the Joint Commission, doing hospital checkups. We're about to release a perinatal sepsis toolkit later this summer, and that's the last of the 5 major causes of death maternal death that we have not addressed as topic-specific ones. We're also, with many other states around the country, working to provide more integrated care for opioid use disorder, both for mother and baby. We've mentioned our QI Academy, which I think is a very important step for expanding QI capacity for hospital teams, teaching them in the context of projects how to do quality improvement on for maternity care. And then today's efforts is on improving racial equity. And this is really a combination of community, our collaborative and hospital efforts all working together. So, some background. First, before we talk about any data of any kind, we have to have some language discussion. And this is really important as we start off here. Let's start with equality versus equity. We all have the myth that we treat absolutely everyone the same. I hear this, I say this, I've said this in the past, I treat everybody the same. That's not good enough, and that's not really what we're after here. That's equality, but that's giving everybody the same resources, is illustrated by this RWJ, Robert Wood Johnson, graphic about giving everyone the same bicycle, even if you're big, small, male or women, or if you're handicapped, you get the same bicycle, but you really aren't getting the same benefits from that bicycle. So equity really is giving you what you need based on your background, how you come into the setting, and you can see that illustrated in the bottom panel. So equity versus equality is a really important concept. Let's talk about equity versus disparities. This is a nice discussion by Paula Braithman, who's one of the national leaders in health disparities, health equity, a public health scientist at UCSF, in this editorial piece. They're intertwined. Health equity really calls on social justice in health. No one is denied the possibility to be healthy for belonging to a group that's been historically, economically, or socially disadvantaged. Disparities are the metrics. Having said that, so Healthy Person 2020 defines a health disparity. Similarly, a little different. Health difference that is closely linked with economic social disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater social or economic obstacles. The quantity, secondarily, the quantity separates a group from a reference point, often measured from the most favorable group rate. Now, birthing justice folks really have pointed out that we really do not want to always be comparing groups to whites, because that is leads to a persistence of racism. If white is the preferred target, everybody's judged against whites, that sets everyone else at a disadvantage. So what we are doing in more and more groups around the country is to compare a given group against other groups as a unit. How does this group compare to every other woman in the population? We'll do some examples of that. Secondarily, though, it's how you define these terms, and disparity is not necessarily an action verb. The other term that we're using now is a gap, closing the gap. So a race outcome gap is, I think, a better way of framing these discussions. Boston Public Health Commission has given a little different definition of health inequity. So differences in health are not only unnecessary and avoidable, but are considered unfair and unjust. So it's a social justice definition. So everyone on the call should be pretty aware of some of these gaps between Black mothers and other mothers. This is percent preterm of all preterm births. As you could see, with the exception of Native Americans, which is less than 1% of the population, Black women have 1.5 times the rate of all the other racial or ethnic groups when combined. Infant mortality is even higher, between 2 and 3 times higher than other racial and ethnic groups. When you look at maternal mortality, which is our area of work, it's even greater. In fact, the Black outcome gap for maternal mortality is 3 to 4 times higher. And national data, and as we'll show in a moment, still in California. And here you see the different color lines representing the different groups. In fact, Asian and Hispanics in this study have the lowest population rates of maternal mortality. Whites are kind of in the middle. The only group that's even approaching non-Hispanic Blacks is Native American, American Indian, which is also a major concern around the country. Many people have tried to organize the health factors that can account for healthcare inequities. This is a common schema. You have provider factors, patient level factors, which overlap in clinical encounter. What happens in that discussion or in that meeting that happens between the provider and the patient? There are also health system factors. There's structural racism that we all have to struggle with. And then on top of that is structural factors that are outside the healthcare system that we're all also certainly aware of. Poverty, unemployment, stability of housing, food security, and racism in the woman's lifespan. These, in some authors, are really overcoming and dominate the discussion. We're going to be able to tease out some areas in which we think we can have an impact as nurses and physicians and community workers. So let's turn to California now. This is data from the California Department of Public Health and the National Center for Health Statistics for our maternal mortality rate. And she saw in the 2000s, the rate rose, both in California and the US. We think a lot of this is related to better data collection. We changed to ICD-9 to ICD-10 for death certificates in around 1999 to 2000, long before we did it for discharge summaries, which wasn't until 2015. So we started better collecting data. There may have been differences also in patient population and so forth, but nonetheless, the rates rose and rose to rates that are above any other Western European or high resource country in both California and the US. So we started our maternal mortality review in California early 2007, the actual meetings. CMQCC was formed then. We did a series of toolkits, as I mentioned before, in quality collaboratives, and we saw some significant changes associated with that, whereas those were not seen with the US as a whole. So let's talk about QI projects and affecting equity. It's a commonly stated point that a rising tide raises all boats. I use the example of Noah's Ark here, however, to illustrate a secondary issue, which is all, but they've got the only boat. So you got to have a boat first to be advantaged by rising tides. Or the alternative is you could have some boats, but they're all full of holes. So all boats are not created equal. So this is an important issue about whether a general quality improvement project, not targeted toward a population that is disadvantaged in particular, will advantage everyone. So let's look at how that works out. So this is a very famous study done in Chicago throughout the 1990s, early 2000s, in which they set out an effort to significantly improve the care for women with breast cancer. And they thought they were improving it for everyone, but most all the benefits and most all the activities were to non-Hispanic white women, NH whites here. And their rate fell significantly, whereas Black women clearly weren't benefiting from these new interventions to improve outcomes of breast cancer. And the disparity widened markedly from a 20% difference in mortality rate in 1990. Whites improved, but now it was a 99% difference in outcomes in 2005. So let's look at some of the possible outcomes. You could have a neutral, you could both have reduced, but it's more of the same. You could have a narrowing in outcome of QI projects, which shows improvement in the reduction of that gap, or a widening of the gap. The gap worsens. So this is an example of New York City, which had a maternal mortality rate that was high. I think they did a lot of work that was probably more concentrated in Manhattan, not in the Bronx or the Queens. And lo and behold, then their maternal mortality rate, their ratio between Black and whites, which is how they presented it, went from 6 to 12 times higher. Again, the national rate is 3 times higher. So all of a sudden the gap worsened, and a lot of that was that whites did better and Blacks maybe did a little worse, and the gap markedly changed. On the other hand, we do see narrowing in racial gaps for childhood immunizations, where the issue is access to a fairly simple intervention. So the immunization rates are narrowed and getting pretty close between Black and white populations in the US. Many projects, though, have more of the same. You might have some benefit for all the population, but you're not narrowing the gap. And that indeed is what we saw in California. So now this is the same data that I showed earlier slide, but by race. Here, so the scale is much higher to account for the much higher rates of maternal mortality in Black women, represented by the red line. Again, earlier years, we saw much better data collection and a rise nationally and in California, and it rose in every single racial and ethnic group, though it rose about 50% in Blacks and about 40% in the other ones down below, Hispanic, Asian, and whites. Everyone fell in the last 8 years through data through 2013 by about 50%, from 51 rate for African American to 26. But look at the dotted line in the middle. The dotted line in the middle shows, in this case, the Black to white ratio or the gap. And it persisted at 3 to 4 times the rate throughout this entire time period. So, more of the same. We did not have, while the good news is that the African American mortality rate fell like other races, we did not close the gap at all. And this has led us to reevaluate what we're doing in California and understand that you can't expect the rising tide to raise all boats. This is similar to work done again in New York City, where this is low-risk cesarean delivery that was published recently. And whites improved significantly, but Blacks did not. And so now you have a gap worsening, a widening gap. Let's look at some other outcomes in California, just current time periods. And this is putting together to look at race with enough robustness on enough sample size. So this is 8 years of data. And the top line is the proportion of each race or ethnicity in California. Our biggest population is Latino, 52%. Non-Hispanic white, 29, Asians 13, non-Hispanic Blacks 5.5%, American Indians well under 1%. Severe maternal morbidity is higher, as you can see here. Severe maternal morbidity, excluding blood transfusions alone, is twice as high. Obesity and comorbidities are higher, but age is younger, significantly younger in the Black population. But at the bottom line, the bottom row, we see that C-section rates are also significantly higher, 5 percentage points, whether it's total or NTSV, the low-risk first birth C-section. That's the national comparative measure. This is interesting because when I trained in obstetrics and gynecology in the 1980s, disclosing my age here, Black women had lower C-section rates than whites. And it wasn't until the 1990s that we started to see a shift, and then that has increased, and we do not have a good explanation for that. So the gap that we see between Blacks and all other races is significant for maternal morbidity, 2 times roughly. So let's talk about what we want to do. And first of all, I want to point out some of the work that we've been doing, looking at why are birth outcomes for Black women so much worse. We looked at our own data, and I have to say, the usual explanation that we start with, this is another myth I'm going to put out there. The usual explanation by doctors and nurses is that Black women have more obesity, more hypertension, more diabetes, more social disadvantages. That's why they have more mortality, more morbidity. I would have said this. I think many on the call would recognize this as a commonly used explanation. So we looked at that. So let's tease that apart. What if we looked at Black to white disparity in severe maternal morbidity only among college graduates? So Black college graduates, white college graduates compared. And we adjust for age, BMI, other clinical demographic risk factors. What do you get? It's still 2.1 times higher in Black college graduates adjusted than for whites. So the relative risk, the adjusted relative risk is 2.1. That's a hard one. You look at the absolute rates. Women who, Black women who graduate from college have a 2.4% rate of severe maternal morbidity, whereas white women who dropped out of college, dropped out of high school, at a 1.5% rate. It's hard to look at this data and say, well, it's about obesity or hypertension. What's left is that we have to look at ourselves and say, there's racism at play here, either in how hospital care is structured, structural racism, or how the interaction between doctors and nurses and patients plays out. So there's some mirrors to look at here as we move forward on these projects. Now, we do a lot of analysis in California by individual hospitals, and that's really interesting because that shows you that averages hide a lot. You really want to look at the variation between hospitals, and that gives you some interesting insights as to what's going on, and essentially showing you that it doesn't happen everywhere. There are places that are doing well with Black women and other places that are doing very much not well with Black women. So, for example, statewide rates are 1.6% for severe maternal morbidity. Black women is 2.4, white women is 1.2. So you look at that ratio, that's a 2, but that's not everywhere are Black women doing worse than white women. This shows you about 20% of hospitals are below that ratio line of 1, the red line, indicating that that Black women are actually doing better than white women. The majority of hospitals, though, Black women are doing worse. This is not risk adjusted. There's more work to do on this, and that's what we're up to next. But there's some hospitals in which Black women do a whole lot worse than whites, and those you really got to be looking at here. This is restricted to hospitals that have a reasonable sample size, at least 150 Black births. So 90 hospitals out of our 230 hospitals, but they account for almost 90% of Black births in our state. So similar type of graph for NTSV C-section. Again, most hospitals have higher C-section rates in Blacks and whites, 5 to 6 percentage points higher, but not all. So we have the opportunity to learn from hospitals that either have low rates for SMM or NTSV among Black women, or have low, in which Black women do better than white women. So there's opportunities to look at the variation and focus in. Conversely, you got to look at yourself your own hospital to understand what's going on. Themes from the literature that we're taking to heart in California is, this is based on interviews with a whole series of stakeholders, including community-based organizations, Black women, and hospital nursing leaders by and large, and some clinicians, other clinicians. Key theme. Fear and lack of trust between Black women and the clinicians that care for them. It's hard to give good care if you don't have that trust. Secondly, lack of shared acknowledgement, perspectives, and understanding of diversity, equity, and inclusion. lack of shared language and meaning between Black families and the clinicians. They can be on different planets, and that's not going to lead to good care. As I was just noting, we have a pretty blind eye when it comes to acknowledging disparities because we're not measuring them and acknowledging them. And that's got to be one of our first steps. Lastly, in this list, there's many other lists that we should address. There's lack of effective collaboration between hospitals and the communities that they serve. So this is a really critical point. They're, again, on different wavelengths, different directions, different goals. So let's talk about trust and listening. Everyone should be well aware of the story of Lieutenant Commander Shaylin Irving, who worked at the CDC, 2 PhDs, and worked in health equity at the CDC. She had a pretty standard birth, but then after delivery, starting getting more shortness of breath, more complaints, brushed off multiple times by her provider, and essentially came in with severe hypertension and heart failure and died within weeks after delivery. And this is her mother raising her child. And the title of this piece by Nina Martin, ProPublica and NPR, is "Nothing Protects Black Women from Dying in Pregnancy." Not education, not income, not even being an expert in racial disparities. We heard this also in Serena Williams' story and here's one of the highest profiled, powerful Black women in the country who had a history of pulmonary emboli. And after she delivered, she started having shortness of breath symptoms and pestered her nurses and her physicians to get a CT scan, and was brushed off multiple times. Finally got it and showed multiple small PEs. So that was a close call. But it shouldn't take being Serena Williams to get the care you need. Now, this is a big survey. It was done in California a year and a half ago of over 2,500 women, and it had a whole variety of questions. Listening to mothers, this is, you all may be familiar with, but this was specifically our state. 11% of Black women said yes when they said, during your recent hospital stay, how often were you treated unfairly because of your race or ethnicity? White, it was 1%, Black, it was 11%, 3% always. So this is, there's a significant population here. Interesting, Asian Americans was also relatively high, which was a significant surprise to me, living and working in San Francisco for many years, where we have a large Asian American population. Now, experience of harsh treatment. This was also a surprising encounter for many of us white people, but not a surprise to many Black women. How often did a nurse or a maternity care provider ever use harsh, rude, or threatening language? Almost 10%, both in Black and Asian Pacific Islanders. There's a study that came out this week with an online survey that said even higher percent. When you ask how often did a nurse or provider handle you roughly, 11%. Again, not a real difference between Black and Asian Americans, but we need to listen to our patients a lot more. This is a general issue about how we are caring for women in maternity services. We can't be using harsh, threatening language. We can't handle anybody roughly. So we have work to do. So our Birth Equity Collaborative is led by Karen Scott, who's an OBGYN who has done extensive work with CBOs in Chicago, now working here in California with community-based organizations, and is a university educator on racial justice. She's the one who should be giving this talk, but the way our schedules worked out, you're putting up with me. So in partnership with the Black community in California, we're doing a multidisciplinary, multi-organization effort to address birth equity. We're building tools, QI strategies to change the medical system. Tools and QI strategies like we have done with other projects. What's different here is that we are working much closer with the Black community and trying to create the bridge between hospitals and the women that they serve. We're starting with a pilot project with 4 hospitals this month and to really test the tools that we're developing. 3 main thrusts, 3 main directions that we're taking in this project, including development of a patient-reported experience measure. In QI, you really want to have a measure that you can repetitively use to show improvement. One of the keys that we want to show improvement with is, are we improving in creating trust, in treating people with dignity, and having folks feel that they're listened to. So these are 3 main things that themes that will be certainly part of this prem. Secondly, a multimedia interactive professional education modules that will be focusing on myth busting, done with a series of Black educators around the country, meant for all nurses and physicians. One of the areas we'll address is certainly bias, but it's more than implicit and explicit bias. It's really what you do with that bias, acknowledging that you have it, but it's really how you can channel that and care for your patients better. Thirdly, will be a set of tools and best practices for interacting with your community members and creating a culture of care on labor and delivery. And creating a culture of birth equity in everything that you do for hospital care, and then we'll move that into prenatal care. So to do this, we need to create a shared language about what birth equity means. We want to acknowledge and amplify the resilience of communities. There are best practices out there. We want to identify and share those. We have some hospitals that are doing a spectacular job with their Black community. That's something that we need to learn from and share widely. And that would then in turn involve establishing strategies to create and assess sustainable and respectful community hospital partnership. So as part of that, it's about transforming patients' voices into action. So we've talked about how the patient-reported experience measure, that's being developed with the Black community, assessed by the Black community in a framework of cultural humility. So this is really, the theme here is community-informed knowledge as we go forward with this kind of project. When you have a metric, you have to have stories to go with it. And one of the keys, I think, because that's how our minds and hearts work as people, as professionals, you look at data, but you also respond to stories and experience. So we're going to be capturing stories locally from each of the communities, from the hospitals that serve them, both as a prelude and then on an ongoing way to match with the metrics that you get from a prem. So this is a piece of work, and we're learning how to do this to connect community and hospitals. And it's going to be ongoing. There's no magic bullet here, but we are going to get some best practices that we would share. All staff need to be engaged in this process. It's not just leaders, it's not just physicians, it's not just nurses, it's the unit clerks or the admitting clerks who can make or break a relationships. It's everywhere up and down the scale. And there are people who are silent observers on our units that actually can teach us a lot, like housekeeping, like chaplains. Many other folks should be involved in this process on a unit. So it's both raising awareness and knowledge as well as changing behaviors. and changing how we interact in a patient-centered way going forward. And we also want to develop peer leadership and coaching, and we have some best practices that we're testing out on that as well. Those who know me know that I'm always interested in data and doing data-driven QI. And we're taking this opportunity to change everything that we do in our data center to provide hospitals the opportunity to look at all of their outcomes and their process measures by race and ethnicity. And when I say we're going to make them look at it, what I mean is that it's going to be, we're taking some of the measures and putting them on the front page, so you can't hide from them. The two that we're starting off with as outcome measures are severe maternal morbidity and low-risk first birth cesarean. We anticipate adding more process measures, measures of what happens on the unit as we develop and go along with those. But here's, for example, a way of analyzing severe maternal morbidity, a real hospital in our system, in our state. This hospital has a much higher rate of severe maternal morbidity among Blacks. If you look at the lower right, it's 4.9%, whites is 1.9%. But we do more than just give you rates. We give you a measure analysis of what's driving that. And here on this hospital, it's really driven by hemorrhage, both 40% versus 23% on the lower right, and transfusion, 34% versus 14% of these cases were attributable to, of the SMM cases were attributable to hemorrhage, for example. So this really then gives people the opportunity to be a little bit more precise in what they need to do. So we're working both at the high level of how you care for all Black women, making that as respectful and appropriate as possible, but then also saying, where do we need to spend our time working? In this hospital, I would focus on hemorrhage. So measures of success would include showing improvement in respect to our patient-reported experience measure, our PREM, demonstrate best practices for respectful, cultural, responsive partnerships, engage hospital staff in completion of e-learning, and then effective use of an equity dashboard by hospitals. And at the end of the day, we wanted a much better culture of birth equity. So there's several frameworks that we're using. Certainly one is reproductive justice. And another is the AIM Equity Bundle, where a group of national experts got together and created some ideas of where to go. Indeed, we are taking that and extracting the key recommendations for our toolkit, which include the collection of self-identified race and ethnicity. We have the advantage in California because we have access to the birth certificate on a real-time basis, and we can give hospitals birth certificate, which I think is the gold standard for race and ethnicity. But it also can allow them to validate their hospital admission data sets or the quality of their race ethnicity data there. And this is important because that's more widely available than a birth certificate. We want to spread the quality of race and ethnicity data and language data throughout an institution. Disparities dashboard we've talked about. I think this is a key step. The ability to review maternal deaths and morbidity at the hospital level. Deaths shouldn't be very common, of course, 1 or 2 per 10,000. But the morbidity is more common, and you should look at these reviews through a racial lens as well as a quality lens. Indeed, one of the points I didn't make earlier is that you can't have quality without equity. And everything that we look at with quality, we should look at for equity at the same time. So community partnership is a nationally recognized issue as well. And that's part and parcel of what we're doing. Bias training, implicit bias training, not enough, and it's really wanting to look beyond that into action and interaction between staff and women themselves. Another really good framework is put out by the RWJ Foundation, and look, solvingdisparities.org. And they have these 6 different pieces, which have also been involved with our project. So number 1, of course, is linking quality and equity. You can't have one without the other. Creating a culture of equity, diagnosing, and then designing interventions. So what actions can you take immediately in your institution? One of the things, first important things, is you got to learn about birth equity. You have to start with a proposition that we all have a lot of learning to do. Next page is a lot of resources. One of the first ones that I'd start with, though, for us white people, is a recent book that's a New York Times bestseller called White Fragility: Why It's So Hard for White People to Talk About Racism. Not a long read, very important. Secondly, you want to examine your organization's data by race. Talk to your patients and community organization. Get some feedback from the field. The more you listen, the more you learn. Well, lastly, on the short list, there's a long list of things that you need to do, but what you want to take immediately is this is a big issue that you need to engage your hospital's leadership on. So you want to get them on board first, the C-suite, but then also your unit's leadership, and start identifying people who can become champions. So this is, the slides are going to be available. So obviously these are all online resources that I think are very useful. We have in our, for more, see above, cmqcc.org. We have a bunch of other resources, and we're trying to triage them, i.e. Each month we have, a curated set of 3 best, 3 most useful resources to look at. Generally short articles or other references to go for. Thank you. I purposely left us about 10 minutes for questions. The CME credit is on the bottom. And let's open it up for questions from the audience. And I think the almost 500 people on the call that bore with me for our 50 minutes so far.
Thank you, Dr. Main.
Sorry about that, Valerie. I just wanted to jump in really quickly, Dr. Malloy, and just thank you for such a great presentation. There's a lot of great information there, sharing data and recommendations and tools and a plan for going forward. So thanks for letting us know we are the people who can do something about this pervasive healthcare issue and get better outcomes for our patients. We just at Anthem, we look forward to working with you further in your team. So we can go to questions. Thank you.
So we did have a couple questions come in. For those of you who are on the call, you can type your question in the Q&A box and we'll be glad to answer it in the next few minutes. We had 2 questions come in related to C-section. The first one is, in your study on disparity in C-section, do you remove maternal request for cesarean? And the second question was, I guess that was the one about C-section, that was the first one.
Sure. That's a hard one to figure out. In most of our data sets, that's a pretty low rate, under 1%. If anything, that is lower in Black women than white women in most studies around the country. And we have seen that in terms of C-sections without indication, which is one way of looking at it, is lower in Black women. So that's not a driver here.
Next question is, the slide says, one of the slides in the presentation said there was a difference by race, ethnicity that they're not significant. What were the confidence intervals?
So one of the interesting points that when you look at data for race, when you start dividing outcomes by race, you have to have sufficient sample size. And that generally means you need at least a year. You can't follow these measures by month. because the sample size will be clearly too small because you're generally looking at subsets of population for NTSV, for example. That's only about 35 or 40% of the births are NTSV denominators. And so you have to look at longer time periods, and sometimes even 24 months is a good one. So we do this as rolling 12 or rolling 24 months, though you want to be able to follow trends more, for at least not depend on 24 months to do that. So because there are confidence intervals, issues when you have small sample sizes. So you have to do that, but you can look at trend lines. If you've always had a difference and you're not changing it in recent months, that means it's unlikely to be different.
So the clarification on that question was it was from the Listening to Mother survey?
Yes, that was the Listening to Mother survey one.
Okay.
There were two ones. One was significant for the first question, the question about being rough treatment was not significant among races, but I showed that because, geez, if you have 8 to 10% of mothers saying they were rough treated, we have issues in our profession, nursing and physician. And some of those answers were physicians, or some of those answers were describing treatment by physicians, by nurses, or even by midwives. So we all have work to do in those areas. The ones that had significant differences was the first questions on the interaction, not the rough treatment.
So we have a lot of questions that have come through, so thank you for all submitting those. The next question is about the current source of the race and ethnicity data. Is that from the birth certificates, and does that capture the race and ethnicity of the mother?
It is the race and ethnicity of the mother. Since this is a maternal project, that's really the gold standard for that. Of course, you can have interracial partnerships, and the baby may be different than the mother, but this is a maternal project. So we do have the race ethnicity of the mother on this.
The next question is how to base programs and knowledge on race and ethnicity when those definitions are often individual or not reported?
The race is a social construct. We should make that clear from the beginning. It's not a biological construct. And so we have to keep that in mind as we go forward. The differences genetically between any of us is minuscule. However, the social constructs are really big. You can look historically, and it's tragic when you review American history or American medical history. The story of Dr. Sims and the father of gynecology is not a pretty one. In fact, it's a pretty terrible one in terms of all the experimentation he did on slave women. So keeping in mind that it's a social structure, social construct, we've approached this by using self-reported race and ethnicity, which is what's on the birth certificate.
Okay, the next question is, what training or preparation do you recommend for hospitals prior to rolling out equity dashboards? And if you're already doing something, how can you deepen the impact of the work? And how can you, what steps would you take for those tools in education after the implicit bias trainings are completed?
First of all, for dashboards, the key is to get it out and to have people and to have a narrative that goes with it. This is really important. And that's why I spent time on the slide comparing Black college educated women to white college educated, because we're all aware of Black-white differences or Black other differences, but we have all created a story that explains it away as essentially blaming the patient. And we really want to move that narrative along with data like what I just showed here today, that it's not because she's obese or hypertensive. When you clear those out, the differences remain. So you have to have a narrative that goes with the data that shows a gap, so that people can't just fill in the gap with their own story and dismiss it. So that's a key part of having a dashboard, is having explanation that goes with it, that these aren't explained by the usual suspects, if you would. Secondly, in terms of what to do after bias training, and I'd say we're not big fans of implicit bias training, as a end in itself. It's a introduction, it's a first piece. You have to have really education about myth busting and about how you are interacting with women of color of one kind, of all kinds. And that's equally, if not more important than recognition of gender bias. So it's really taking those next steps that are really important.
Okay, any thoughts or comments on addressing disparities in Native tribal women?
We're focusing first on Black women in California, with the feeling that they are the group that has the greatest gaps. We think many of the strategies will be effective for other communities, though each community is going to need its own work. In California, unlike some other Western states where there are larger concentrations of Native Americans, our Native American women are scattered. We have some we call rancherias, so they're very small reservations. And it's not, we have a couple that we'll be working with, but to date, this project right now is starting with Black women. We think there are lessons to be learned for all and for other highly disadvantaged groups.
So from a medical perspective, from a medical managed care plan perspective, how can we make sure to effectively engage with our hospitals?
First of all, I think I made it clear at the beginning that we spent a lot of time talking about gaps, talking about disparities, talking about equity in the last few years, but we haven't figured out the exact and tested the exact approaches to take. We think it is clearly going to involve community, and that's a given. We think it involves actual engagement with your own data. And we think that there's training that are key steps. Now we are, like we've always done with all of our other collaboratives, we are testing the specific intervention tools on pilot hospitals before we share them with a broader audience. There's some things that we're going to be able to share in the next months, but to have a toolkit that you want to share, like our hemorrhage and hypertension toolkits, you have to run it through pilot projects first before it's ready before we can confidently say that this would be a useful approach. So bear with us a few more months. We, as always, will release everything when it's done, but those are key steps. So what a managed care plan can do is encouraging hospitals to work on this issue. And that would include community engagement, that would include regularly analyzing your outcomes by race, looking for improvement opportunities, and doing awareness training with a focus on treating everyone with dignity and respect, and other issues that we've spoken about today. So those would be my starting points while we work out specific tools that will be shareable.
Okay, is there any partnering with licensed midwives who provide community-based care? And do you see any role for Black doulas?
Absolutely. As we've been reaching out to community-based organizations in the communities of our pilot hospitals, which include Los Angeles and Oakland and Riverside counties in California, those groups are actively engaged. CMQCC has always been multidisciplinary, so there's active participations of midwives, physicians, nurses, as well as hospitals and everybody else. So the professionals involved have always been midwives and nurses. In this particular project, we are absolutely focused on reaching out to community groups, including doulas, Black doulas, and licensed midwives who are doing community-based care.
Great, thank you. We are just about at time. There's a lot more questions. We will capture these and reach out to you individually with responses. We'll thank you for your time on the webinar today, and thanks, Dr. Main, and thank you to Dr. Molloy from Anthem. With that, we will sign off, and thank you very much. Have a great afternoon.
Thank you.